Very good.
Do you want the list of people that are here? Wait till the end. Okay. Yep.
That's it. That's a quorum.
That's Butterfest, right? All right. Good morning, everyone. Ready? Thank you all for coming. I know it could be we could be sitting on a nice warm beach somewhere. Instead, we're in this cold wave. But it's going to get warmer. Tomorrow's going to be 32 degrees, so we're going to be in a heat wave starting this week. One of the things I thought about for the new year, and Happy New Year, everyone, was that I know we have this meeting slotted for 9:30 to 12:30, but I just want to make everybody, and maybe we can, assure people that the meeting will be like an hour, hour and a half. It's rare we go to the 3 hours, and I can't remember the last time since we bring things out of here and into other committees. It makes it so that we don't have to do a lot of, hands-on work here. So one of the things to, put in your schedules is you could safely say we should be out of here by 11:30 every time so that people can make sure they get here and come. And I know 9:30 to 12:30 is very discouraging sometimes and to block out your schedule, but I appreciate everyone's efforts. And everyone's attendance has been fantastic this year. So that's being said. Karen distributed the minutes. They were reviewed. Can I have a motion or comments for any corrections, deletions, any kind of alterations at all?
Motion to approve the minutes.
Okay. Is there a second? Thank you.
You got to verbalize for me, Dr.
So,
Butterfest.
Dr.
please.
Butterfest.
Thank you.
Sorry. Thank you. So under old business, we need to talk about psychiatric patients and dispositions. That was supposed to be a tag, no?
I don't know. I
Well-
thought you were doing a report on it.
No, what happened is I've reached out to the state and to the Orange County because that's who I have the closest contacts to. And so what they're looking at, and it's actually in the state of the state process or report from the governor, is they're looking at trying to make certain facilities and places age-specific kind of treatment, and to look at can we improve the access to psychiatric care in the state, because as you know, it's like a nightmare. So as of right now, they've made no changes. There is things on the horizon, but nothing has been written in stone to say this is how we're going to make it better, because as you all know, we're in dire need of more BHU psychiatric beds. In terms of dispositions and where people are going, I think people are doing better at addressing the patient's needs from a medical perspective before just transferring them to a psychiatric receiving facility. Anuj, I know you're just taking your coat off, but do you have any issues for like the whole thing? We brought this up before about psychiatric patients and dispositions, and where patients being, medically cleared and then sent to the 939 receiving and such. Any improvement, any changes, any comments?
I know that in the past, one of the comments we had were for patients bypassing other EDs, so I think that's gotten a bit better.
I think so too.
Yeah.
Right, not as many complaints and not as many individual cases where they used to come across my desk.
Yeah, agreed. But in terms of our capacity, we're constantly full and challenged with space, so when the ED becomes an unsafe environment due to our volume, we can't always accept every patient that wants to be transferred over because of our capacity and resources. So we're doing the best we can.
Any comments from other counties? Any problems, issues, concerns?
Has there been any progress made on sort of the whole substance abuse thing in terms of referral to that?
No. I mean, there's been a lot of talk at the state level, but I have to say nothing's formulated. People talk about it, that we have to have some kind of place to refer these patients to, and into facility or a place that'll work for them, not just a place that they're going to go hang out and, chill. It's a place.
Expensive urine test.
Yeah. More so a place that really will help them, get better. New Jersey has made, I don't know if you've been involved or in the conversations are totally dissolved from New Jersey, but New Jersey has made huge strides at ways you can see the commercials on TV. You can see the hotlines. They've made big strides at trying to get people into programs and get them out of that vicious cycle of using. But I haven't seen anything yet from New York. Beyond what we've done. Beyond the one push has been really getting Narcan out there has been our biggest push throughout the state. But I haven't seen anything on the flip coin of it, of rehab and trying to get people better. Not much. Any other comments or concerns? Okay, BLS protocols update. So we've been meeting all along. I don't know, Mike, if you want to jump in. We've been meeting all along, a lot of back and forth emails, and we've had split up all the BLS protocols amongst many practitioners to look at, to review, and bring back to the state. So the state is compiling them. We should be almost done, right? I mean, I think we're bringing forth tomorrow the last of the first drafts of all of them for the committee to look at and go to the state. As you know, tomorrow Lee retires. Lee Burns retires. That's who we've been kind of driving this all with. So I'm not sure what's happening. Are they replacing Lee? Are they replacing Lee?
Yes.
They are.
Who is that?
Rich.
State Health.
Sorry.
The
we.
acting director currently is Andy Johnson.
Oh, he's going to take that hat on for right now.
He was the highest grade in the office, so
Okay.
he won,
He got the short straw.
I guess.
So we should be able to move them along tomorrow. So we'll see what happens. But pretty much we went over and upgraded all of the BLS material to include the newest modalities that have been brought forth for their curriculum. And I don't know, anything else to?
No, tomorrow it'll be a good discussion to see where we're at. But they're not looking for a motion to adopt them tomorrow because there were lots of comments from the MSC and from the STAC. But other than that, it's just moving forward.
Yeah.
Maybe at the next meeting.
Yeah, they'll go through standards in the morning. We'll
Yeah.
discuss some of the stuff and some of the comments that have been made. So that's on the horizon. It's well into it. People, work pretty hard on all these things. It's been a great effort from many, many people. Okay, service upgrades. I have none on my stuff. You have anything? Nope.
No.
Evaluation subcommittee.
So we do have one case to review, and it was referred to Jeff via Dr. Stutt, who was formerly sat on the REMAC for several years, regarding a 66-year-old male, the date of service was in October, who presented with respiratory distress and ALS was dispatched to the scene. So I'm just going to do some reading from my notes here.
Do it slow, Dr.
Thank you. There were some communication issues which we'll be discussing, as well as some medical management issues. The summary as described by Jeff is the patient had recently undergone successful surgery for lung cancer and was recuperating at home with wife and family when he was found to be in respiratory distress. The initial vital signs are reported, including a peripheral heart rate of 150 and an oxygen saturation of 98%, with an initial assessment of the patient in moderate respiratory distress. One of the concerns the family had is that no attempt was made at an oxygen saturation within the home due to, or rather there were challenges in obtaining the oxygen saturation at home because the patient was diaphoretic and clammy, and in review of the PCR, the initial saturation is reported at 92%. There was also concern in regards to the transfer of the patient onto the gurney. They said EMS did not help facilitate the transfer of the patient onto the gurney. In the PCR, the documentation reads that family and PD helped with the facilitation of the transfer of patient onto the gurney. Now, one of the main issues that came up was the code status of the patient. So a lung cancer patient that had undergone a recent lobectomy at Vassar. Apparently the family, in review of the HealthQuest note, had conversations regarding the potential code status or changing the code status of the patient. However, the patient remained a full code, and they re-emphasized that the lobectomy had been successful in removing the area of cancer. Now, the paramedic in the back of the ambulance who was teching thought that the code status was in fact do not resuscitate. The patient's wife was riding in the front of the ambulance and was the healthcare proxy. There were challenges in obtaining a successful IV, which are corroborated in the PCR. During the transport, the patient degenerated into a pulseless electrical activity, or a PEA, and became minimally responsive. BVM was initiated by the paramedic and pacer pads were placed. There was communication from the back of the ambulance cabin with the healthcare proxy, and the communication was unclear, it seems like, though the wife indicated that the patient should be resuscitated fully. Ultimately, there were challenges in electrically pacing the patient, though in the PCR it says pacing electrically was considered. The care was transferred over to Vassar Brothers, where the initial management was relatively conservative until the patient's daughter, who is an ICU nurse who works for the Healthcare Alliance of Hudson Valley, phoned into the institution and said, no, in fact, the patient should be full code, and then all measures were taken. Now, in regards to the review, the PCR is written with incredible eloquence. When we discussed with Matt, one of the supervisors with the agency, there was some communication with the paramedic who was admittedly flustered. So nevertheless emphasized that her impression was the patient was in fact a do not resuscitate. There was some education done regarding bradycardic rhythms, pulseless electrical activity, and management of electrical patients, especially in decompensated shock, which was received constructively. So that is the case. I just wanted to see if there are any questions which the committee might have. Ultimately, we determined that there were some communication issues. The paramedic was re-educated and accepted that constructive criticism as well. Some of my thoughts are code status is certainly something that's challenging, and when there are questions or it's dubious what the patient's code status is, it's always appropriate to be more conservative in the management and assume that the patient should be resuscitated as a full code. Additionally, some things that I've seen as a EMS medical director are there are a couple of things which remain challenging because they are described as HALO encounters, and that's HALO, high acuity, low occurrence. And managing symptomatic bradycardia is in fact one of those challenges and issues, and in fact is something that is not only a limitation at the paramedic scope of practice, but in fact as emergency physicians, we do not see that as often as well, and it's something that we have to be diligent in regards to maintaining our skill set and proficiency in that regard, especially when we get into transvenous pacing and the intricacies and nuance of both placement of the electrical wires and then management of our electrical pacing device. So some of our summary statements are in regards to symptomatic bradycardia. We should emphasize that these are rare occurrences, but nevertheless, The patient is often critically ill, so we should engage in situ, SITU simulation to not only practice the skill set of chemical and electrical pacing, but also embed these scenarios in a simulation so that we can upgrade our paramedics' medical decision making. Especially for younger paramedics who may not be as used to these scenarios that may occur 1, 2, 3, 4 times in an entire career. It's important in regards to these like critical airway interventions. Symptomatic bradycardia is something that comes up over and over again. The management, pacer pad placement, as well as something that is also really common is patients in moderate respiratory distress are often given an albuterol nebulizer rather than immediately being placed on CPAP for positive pressure support. So these are some of the things that we should continue working on.
They're trying to get tachycardia out of that albuterol.
Yeah, absolutely, absolutely. So that was a case that was referred to us. The paramedic was slightly flustered, but nevertheless, I think one of the takeaway messages, if the code status is unclear, treat conservatively, and for the high acuity, low current types of cases, especially with a critically ill patient, we need to rehearse those scenarios via simulation beforehand so that when the need arises, we're able to initiate treatment appropriately.
Well, when's the last time anyone saw a transvenous pacer being placed? I can't remember.
I place them.
Do you?
Yeah. It's relatively easy now with the use of ultrasound guidance in regards to knowing the correct location, because the typical teaching is we attach like a V1 electric EKG spike to the device, and when we see extreme ST elevation,
We hit something.
then you know you're abutting the right ventricle, which is the appropriate location. However, in modern ages, with a subxiphoid view of
Say
the
that again?
heart, in modern ages with a subxiphoid, XIPHOID, view of the heart, with 2 practitioners, you can actively view the pacer being placed and abutting the right ventricle. The challenge, though, and I think one of the teaching points that we've undergone with nursing staff as well as attending physicians is titration of your electrical pacing device. And I think when we're using a transthoracic approach, many of us are comfortable or essentially can jog our memories enough to be comfortable, but especially with transvenous pacing, you have to rehearse the algorithm so you know the appropriate amperage to obtain electrical capture.
Any other comments or concerns about the case? Okay, thanks, Ashad. Next is helicopter committee report. Dr. Berkowitz isn't here. Have you guys met? Do you know? Okay.
No, I've seen no scheduled meeting.
Yeah, we have no meeting.
Okay, so that's a quick report. And RTAC, I know RTAC met.
Not since the last.
Yeah.
No.
Yeah.
Oh wow, we're that
It was
close
just
to
before
the
that.
to the other one, right before that?
Yeah.
Yeah.
So, wow, there's
Because
a,
there was a tag that was formed here as the result of discussions from the
RTAC.
And that was in regards to giving or helping give guidance on patient reports.
Right, that's correct.
Okay. QI report, Jeff.
The state has been rather busy in the last probably month working with EPCR data and making sure everything has been accurate. And we've been tasked with multiple reports of issues that need to be fixed before they can move to the new bridge, the 3.4.0 version. One of the issues was we had episodes of patient cooling post-resuscitation, which we know doesn't happen. And that was a mapping error. It was an ice pack that was placed on the patient, and it mapped to that. So there have been a number of issues that we've been tracking down in cooperation with the vendors to get that fixed before we move to the next version. And that's been occupying a fair amount of our time.
Okay. Protocol Committee, Michael.
I had nothing other than tomorrow we're going to meet again and move forward. But
Yeah, and we've had a bunch of discussion. We do a lot of electronic discussion from the collaborative committee, looking at a bunch of things that people have brought forward, concerns and questions. I would say a lot around oxygen, a lot around the resuscitation. When do we, say we need to put supplemental oxygen on people? What kind of oxygen, and how to move forward with that? So that's been a lot of the discussion. It's mainly been really looking at the BLS protocols, though. We did some tidying up of drug dosages and making sure different protocols have the same dosage so that we keep it across the board the same. But I would say that was about it, not too much else.
Is there also going to be discussion regarding the AEMT protocols? I know there have been some electronic communications regarding that.
there is I believe, a tag that's looking at those issues now that we don't have critical care any longer. So I would say that I think we'll probably take 2018 to make the necessary changes, and I wouldn't suspect that we'd see a change until maybe January of 19. We'll probably work the rest of the year on, these minor updates, and then release something later 18 or early 19.
Okay, flying along here, guys. Okay, new business. Anybody has any things they want to bring up? Yes,
Morphine shortage.
Mr. Parrish. Yeah. So I know. Would you ever think there'd be a morphine shortage? It's impressive. Each one of these drugs that keeps adding on to the list comes on for a little while, goes off, and then comes right back. But morphine, this is its first time that I know of coming up onto the list. But I was going to bring it up tomorrow. We're having a collaborative committee meeting after CMAC, so I was going to bring that up because it's one of those things where there aren't too many. Depending upon what you're using it for, there's not too many ways we can substitute. The only other thing we have on board is fentanyl, so it's a kind of sticky wicket.
One of my agencies, and we don't supply them, but they called us to see if we could assist them. And when talking to my pharmacist, she said that in the hospital we're using hydromorphone.
Yes.
Hopefully I'm using the right thing.
No, that's correct.
Right? And so, we're not in a position to help them with the morphine, and because hydromorphone's not on their protocol. That's why I brought it up here.
Yeah.
What's their options?
Not too many. I'd hate to see us move forward and substitute hydromorphone on an ambulance. We're trying to get it to stop being used in the emergency department because people come in and ask for it now. So it's a thing where I think if the one place is, when we use it for cardiac causes, is the one place that we really don't have a substitute. But if it's pain, we can definitely use the fentanyl. But it's going to be a difficult issue because we really don't have a good substitute for it. Were you going to say something, Jeff? Nope. Oh, okay. Sorry, I don't have an answer for that problem. Also under new business, I sent to Karen a copy of the Governor Cuomo's State of the State address, his proposals, and in it, for the first time that I know of, Dave and I were talking about this, is a portion, and it starts on page 254, and you'll have the whole that section to read. Proposals to strengthen the rural emergency medical services system. It's the first time I've seen it directly related to EMS, and that there's a clause in there. It goes on to talk about, he's going to talk about promoting careers in EMS or authorizing community paramedicine, increase the availability of EMS training in diverse settings outside of the traditional paradigm, and advanced materials to enhance training and leadership for leaders in emergency medicine, emergency medical services. So, there's quite a bit there. I thought it was pretty impressive that someone in a government position as i.e. our governor talked about this. I don't ever remember it being addressed to this extent. So pretty exciting. We'll see what happens, but I sent it to Karen, so she will send all of you a copy so you can read it. Very interesting. And hopefully these things will move forward. Community paramedicine, if that moves forward, that'll be a huge role for the pre-hospital provider. Anybody else with new business?
I have two brief Vassar updates. So the first one is a project that we're working on with Karen. We had many providers being reported as not being MAC'd, and that was due to a high volume of locums physicians who are no longer active at Vassar. So we're working with Karen to get updated lists and a roster to accurately reflect that. And then there were a few stragglers who we have been able to track down, and we'll get that information to you shortly, as we've also just hired a new EMS coordinator named Dave Jensen, who unfortunately could not come today because it's his first day of HealthQuest orientation. But we really look forward to working with you all on many new initiatives in the coming year.
Excellent. Anybody else? Okay, CMAC report. Well, we have our meeting tomorrow on the 10th, so I'll give you that report next meeting. We did do quite a bit. They asked a few of us to be on a appeal committee, so we had to review a large process that occurred in Nassau County, and they wanted it to be reviewed by practitioners and members outside of that area. So I was selected on this committee, and we worked through it. We'll announce our findings tomorrow. But it was it's the first time I've seen like a small committee off of CMAC work so well, and kudos to Dr. Bart. He put it all together, and I think it went very smoothly. And we will announce all those findings tomorrow. In terms of CMAC, like I said before, Lee is retiring tomorrow. Tomorrow night is her retirement celebration. It's at 6 o'clock after CMAC. I forget where it is.
Revolutionary Hall.
Okay, Revolutionary Hall. It's in Troy, right?
Correct.
Yeah, I remembered it was in Troy. And so if people want to go, there is a small fee that includes dinner, gift, and it is through the office for CMAC. Next, I have no pad, EpiPen, albuterol, glucometer applications, but I do have some state violations. For Kelly Omland out of East Islip, New York, she has a suspension for 18 months effective December 18th. The actual suspension will be 3 months. The remaining 15 months was stayed for she's placed on probation. I guess I'm not going to be able to tell you exactly why, but it says she has to provide an alcohol evaluation, so I can only imagine what that means. Second is Vincent Liardi out of Holtzville, New York. He is under investigation of the Department of Health, and his New York State certification was revoked for a violation of Part 800. Lastly, Richmond Medical Center, Staten Island. The Department of Health conducted a investigation, assessed a civil penalty of $5,000 for violations of 3 areas in Part 800. So, Richmond Medical Center. And it's, as of this date, there is no other, just the civil penalty. Those are the 3 standing violations read into the minutes. I have nothing else. Holy moly, this is going to be a record. Remember how I said it should be like an hour and a half? I think we just did it in 40 minutes. 30 minutes. 30 minutes. I think what we need to do, though, we should have moved this meeting to next week, so then we could have had all these things, because, CMAC and all these, and Protocol Committee were all meeting after this meeting, so that's why there's not much to report. Any other open forum? Anything else anyone wants to bring up?
Maybe we should just look at that for the remainder of the year. I know the calendar
The
is
next
out.
one would be May after that, and then June 4th, so that would probably be appropriate. That would probably work out fine. And I think it's September after that. I'm not sure of the dates, so.
Yeah, because sometimes we don't get the CMAC dates till,
Well, the next one would be okay.
Yeah, but, yeah.
The next one, I don't have the dates in front of me.
Yeah.
Yeah, I think the dates did come out for CMAC.
Did they? Okay.
Till January of next year.
Oh, okay, good. So then we'll make sure, we look to see if they match up.
Yep.
All right, any other concerns, issues? All right, thank you, everybody. Can I have a motion to adjourn?
Motion to adjourn.
A second? Thank you. Thank you all for coming.
Did you get everybody who came in late?
Yes, I got them all.
Do you need this back, Dr. Murphy?
You can just give it to Karen afterwards.
Yeah, we need that.
You heading back to the hospital?
What's that?
Heading back to the hospital?
Yeah, I got to work at 11.
See what our volume's like, might be down.
There's 10 holds right now.
Just 10?
Yeah.
So I'm trying to look at this weekend. In terms of our door knock times, and I know when it's high, it's always good because we can't get back away.
We did pretty good. I got it down to 13 Saturday morning.
Okay.
It went up, spiked a little bit Saturday night. Went down to like 18 yesterday morning. So
I think I have my staff signed it, that I couldn't find that. Looks like activity for the training.
Okay, it's a combination of this one.
We're getting bounced back. Yeah, but usually when they do that, you list them.
Yeah, I don't know why it did
yeah,
that.
no, and people are calling me now and
I start
asking
looking
me,
at
so I
this, I
review them
see
and then we talk about it a little bit.
1,200
One last
Well,
night.
what happens is we pay a portion.
Okay.
That's the full utility bill for the building.
Ryan
All right.
said,
This
"You
is
know,
our
what do I got with
portion.
this guy?" So I looked at it, and there was some EKG.
So
so I was like,
we paid a 107.88, and then we pay this one, which is 127.53.
how old?
So it should be 234.41,
You know, as long as-
235. Yep,
Like,
carry
look
one.
at that note I sent you from,
235.41.
Okay, so then I should initial that over.
Yeah, this one and this one.
Shaw? It was impressive to do. You should put that up on the screen. She was
You
sending
see, this
them
one
live.
is 917. Now, when I enter this, remember, I was talking to Nick about it. When I enter this, I enter this stuff. I enter this onto the detail, and then I enter this on the detail. So when I pull it up, I see that detail.
And
Trying
documents.
to get that detail like here.
But no, I'm not gonna go after anybody for that because we're trying.
Everything shows up because I use the same program. Now with this program, it's not showing up here, and we can't figure out. We spent like an hour looking at it the other day. We can't figure out how to get this down here because it gives us the original amount, the balance amount, the discount, and the payment. Those numbers are always going to be the same because we don't need that. So we should be able to put the memo column in here, which would then list all of this stuff that we put into the memo.
That's when I sign it. I
Yeah.
look for. All right, I could. All right. Very good then. There you go.
Thank you. Did you sign the 990?
Yes.
So we're good on the chart 500?
Good to go. All right.
Excellent. Thank you.
Okay. See you up there.
Yep, I'll be up
Yeah,
there
see you
tonight.
tomorrow.
Are there tickets still available for these things?
Yeah, I think she doesn't care as long as, people, because I haven't even paid her. She knows I'm coming. I RSVP'd.
Yeah.
But she said, just pay me when you get up here. So I think it's pretty low key. It's not crazy. Like, I think it's a pretty big place. So, I don't think they have to shut people off.
Because she sent out a note the other day saying that it was a cutoff, and I thought we could pay when we got up there, so I didn't, because I wasn't sure I was going this time.
Oh,
So-
when was that? She didn't send that to me. That's funny.
No?
Maybe she sent it to other people.
Maybe it was anybody who did.
Yeah, because I told her she knows. Supposedly it's this big place.
Yeah, I don't know what it is.
Unless it's a thing for the caterer or something that
Maybe.
they need to know.
The count of
Yeah,
number
how
of
many people.
Yeah.